Welcome to this meeting of the Calderdale and Kirklees Joint Health Scrutiny Committee. I'd like to welcome any members of the public who are attending. I have sad news that since our last meeting, Councillor Marilyn Greenwood, who was a councillor for Stainland Ward in Calderdale, has sadly passed away. For some considerable time, she was a member of this committee, and I'd like to ask Councillor Liz Smage, who was chair at that time, to say a few words.
Thank you, Councillor Hutchinson. I think this committee should record our deepest sympathies to Councillor Marilyn Greenwood's husband and family and colleagues on the very sad news of her untimely death. Marilyn was a joint chair of this committee in 2016-17, at a time when the committee's report and recommendations were being put together. It was a lot of work, but it was a key part of this committee's role. A passionate advocate for health provision, Marilyn was greatly respected by all of us who worked with her, and I'm sure she'll be greatly missed by many. And I wonder if this committee can send a letter to her family expressing our sympathies. Thank you.
Thank you, Councillor Smage. We'll put together a letter between us and send that to Ed on behalf of the committee. So starting this meeting then, do we have any apologies for absence, Kirsty?
None that I've received, Chair.
Thank you. I'd remind members to disclose any interests, pecuniary or otherwise, they have in any items of the agenda, either now or when those matters arise. Are there any interests to be disclosed? Councillor Swift? You're on mute, Councillor Swift. Councillor Swift, you're on mute.
I know, I can't get off it. I have now, haven't I?
Yes, yeah, we can hear you now.
Hard line. Yeah, no, I'm on the governor's board at the hospital, so I'd like to declare an interest, but not a pecuniary one.
Thank you, thank you.
Because they don't pay me.
Or can I remind members that if you have a question to or comment to make at any point during the meeting, if you can raise your hand in the participants box, then I'll keep an eye on that. I have great difficulty keeping my eye on too many different boxes at the same time. So if you can try and restrict yourself to the participants box, that would be great. This meeting there's no recommendation that the public be excluded from this meeting for the consideration of the items of business on this agenda. If we turn to item 4, the minutes of the last meeting, Calderdale and Kirklees Joint Health Overview Scrutiny Committee from the 25th of September 2020. Those have been circulated. Are they an accurate record of the meeting?
I move the minutes, Councillor Hutchinson.
Thank you. Do I have a seconder? Yes, thank you, Councillor Blackburn. Deputations and petitions. I'm aware of 4 people who would like to make deputations. You have 5 minutes each. Can I suggest that we've had a deputation from Hands Off HRI. Can I suggest we hear that first? Is there anyone who's going to make that in person? Otherwise,
hello, Chair.
Hello.
Yeah, there are actually 2 deputations from Hands Off HRI, I believe, but I'm presenting one of them.
Okay, would you like to, let's hear this. You have 5 minutes.
Thank you. Yeah, the deputation is regarding clinical codependencies and the proposed A&E at Huddersfield Royal Infirmary. At the public meeting of the Joint Committee in February 2019, and again following publication of the April 2019 updated strategic outline case, in July 2019, hands-off HRI deputations queried the suitability of the proposed A&E at HRI as described in the SOC. In particular, whether it will have the necessary clinical codependencies to make it a full, known as Type 1 A&E. There's no satisfactory response was received from the committee or from the Health Trust, nor any subsequent improvements addressing these concerns made to the hospital reconfiguration plans. We're raising the query again. The question of clinical codependencies for A&E departments has been considered by, in particular, the NHS South East Coast Clinical Senate and by the King's Fund. The SCCCS carried out an extensive review of the evidence base and a comprehensive clinical review of interdependencies between acute services and A&E departments. They concluded that necessary on-site services required to support any A&E department, even those not taking acute patients, include acute medicine, respiratory medicine, urgent GI endoscopy, cardiology, trauma, adult critical care, urgent diagnostic, haematology, and acute mental health services. Similarly, the King's Fund review of evidence on service reconfiguration finds that key clinical and service interdependencies for A&E departments include critical care, acute medicine, acute surgery, paediatric expertise, and access to inpatient beds. The strategic outline case in the state section 7 notes that HRI is currently the centre for emergency surgery, planned complex surgery, and emergency paediatric surgery. Under the future service model, however, these specialties are to be removed to Calderdale Royal. Blue light ambulances cases in general will go to Calderdale, as will cases requiring complex surgery or critical care after surgery. Huddersfield Royal will retain an A&E for walk-in patients. Of these walk-in patients, a small proportion will be critically ill and need rapid and comprehensive emergency care. For the public of Huddersfield, the nature of the A&E is critical. Our understanding of the strategic outline case and other trust documents is that HRI's A&E is not in fact to be a full A&E. Formerly, I understand, known as a Type 1. One where the essential clinical codependencies to treat critically ill patients in a timely fashion are available on site. Critically ill walk-in patients under the SOC will instead have to be transported to Calderdale, causing delay, potentially an unsafe arrangement, leading to more adverse outcomes, increased morbidity, and even deaths. We accept that it is already the case that patients are transported to other hospitals for particular acute conditions, such as head injuries, but nevertheless, this has not been the case for the many HRI patients who require more routine, critical and acute treatment and care, who have been able to be treated at HRI. But this level of service will no longer be available to Huddersfield residents locally, and others living or working within HRI's catchment is, we would argue, to their significant detriment. Therefore, and noting that many of the essential A&E on-site clinical codependencies specified by bodies such as the King's Fund and South East Coast Clinical Senate are at present lacking from the strategic outline case proposal for HRI, we request that the committee, 1, look as a matter of urgency once again into the matter, and 2, make suitable recommendations such that the necessary and fully staffed clinical codependencies for a full A&E department be provided on site at HRI. Thank you, committee.
Thank you, Mr. Slater. We'll endeavour to get some clarification later on at the appropriate point in the meeting.
Thank you, Chair.
Now, there was another deputation from Hands Off HRI. Is there anyone to make that deputation? No. In which case, are you able to read that out, Mike?
Yes, I'll do that, Chair. Perhaps Richard will time me. It's deputation to the committee 19th of March. For any change in public services, particularly health services, there is a need to ensure that future plans have the service user and patient at the centre. There should be a commitment to develop plans that do not disadvantage the most vulnerable in our society, and every help is given to those who struggle, whether that be physically, mentally or financially. The plans that the Trust have developed do not do this. The latest plans for transport are not based on good evidence. How can a survey on transport undertaken in November 2020 hold water? This country was in the middle of a pandemic. Hospital services were not running as they had been 12 months ago. Visitors were not allowed into the hospital, and many outpatient clinics were being held remotely. People were being told not to use public transport unless it was absolutely necessary, and many people were either shielding or staying at home as the government had asked. It is plainly wrong to plan services and responses based on data that is collected in extraordinary circumstances. The report states that 0% of visitors to HRI used public transport. That may very well have been the case last November, as there were few visitors to inpatients in the hospital, and it would be interesting to know the sample size rather than the percentage to be able to gauge whether if this assertion is based on numbers that are statistically significant. There is also an assumption that staff and others will increase their uptake of cycling and walking to each hospital. Even the hardiest of bike riders and walkers are unlikely to make the journey to hospital in the depths of winter with dark mornings and nights, inclement weather, and issues with safety. The way that data is shown puts distance in different bands. The under 1 mile is fine, but then to jump to 1 to 5 miles is a bit of a stretch. There is a huge difference in walking or cycling 1 mile or 5. Within the report, there are figures given for car parking at both hospitals, 863 at HRI and 709 at Acre Mills and 809 at Calderdale. However, nowhere in the report or the online consultation is there a figure given for total number of spaces that will be made available in Calderdale. Even during this pandemic, car parking spaces are at a premium in both hospitals, and to ensure safety and to avoid disruption to neighbourhoods, more information on this would be helpful. It is understandable that the shuttle bus between the hospitals is restricted at this time. However, it is our understanding that in the future, and entirely contrary to the 2018 recommendations, section 2.6 of the independent chair of the Travel and Transport Review Group, this will not be available for patients and visitors. The cost of bus journeys or taxis over the greater average distances prevailing under the hospital reconfigurations for those on low incomes, whether patients or visitors, is prohibitive. It is clearly evidence that both children and adults recover better and more quickly with visits from parents, carers and family. Therefore, the Trust seriously needs to consider how they can put plans in place that will allow patients and visitors to be able to both to afford to get to the hospital, and that specify that any provision is fully accessible and is made available free of charge and at all times when it may be needed. It is not good enough simply to label this transport need, as the Trust themselves do, as falling primarily outside the Trust's remit. The problem has been caused by the Trust's decision to reconfigure hospital services. To fail to provide a comprehensive solution is to make the poorest and most disadvantaged pay heavily for the claimed deficiencies and cost savings of reconfiguration. It is a matter of equity. The Trust must provide equitable access to hospital and medical services for all groups, such that they are not disadvantaged by the reconfiguration. Hands Off HRI has had a number of communications regarding access to acute services for those living in outlying areas. There is a view that the proposed changes will make travel times prohibitive for some, particularly at peak times, or if you are trying to make the journey using public transport. The report itself shows the frequency of public transport which is available to HRI, not just from the town centre, but from outlying areas. We would ask the committee to seek a full response from the Trust on all of the above concerns, to demand that better, more comprehensive reporting is made available on a regular basis to the committee, to the public and to Hands Off HRI, and to require that the particular issues highlighted in this deputation and patient and visitor transport issues in general are fully and thoroughly addressed to the committee's satisfaction. We would also very much appreciate an early written response from the committee to the issues raised in this deputation. That's it, Chair.
Thank you, Mike. I mean, at this point, I would say that it's necessary to remind people that we're not a decision-making body. We can only make recommendations in terms of any response that we might make. I'm sure quite a number of these points will be discussed under item 7 in the agenda, where we're looking at the travel plans. Jenny Shepherd, would you like to make your deputation?
Yeah, thanks, Chair. So again, thanks for the opportunity to make this deputation. I'm speaking on behalf of Calderdale and Kirklees 999 Call for the NHS. Our position is that the Hospital Trust's future plans engagement is invalid, and our reasons follow. The future plans public engagement does not provide any information about the capacity of the new A&E buildings. The engagement questions have a range of tick box options to say what's most important to you in various aspects of the new A&E and their surroundings, but there are no options to say what's most important is that the new buildings have the capacity to safely meet the future needs of the Calderdale and Kirklees population. There are, however, other write-in options, and we're using that to make our points. Equally, there are no tick boxes to say whether it's important to you that the A&E is big enough, with enough A&E staff, including consultants and anaesthetists, that it can properly and accommodate and promptly provide appropriate treatment for all patients on an open access basis, and that's including during winter pressures. We want the A&E capacity to be based on factual evidence, not the assumed ability of care closer to home to avoid the need for accident and emergency attendance. Nor does the engagement provide any assurance about the safety of the planning decision to keep hospital bed numbers at 2019 levels instead of increasing capacity to take account of the forecast increase in hospital usage from demographic growth, and that the reference for that decision is the 2019 Strategic Outline Case, page 13. The Hospital Trust's justification for not increasing acute beds in line with forecast increased admissions is the Clinical Commissioning Group's aspiration that their closer to home services will reduce the need for acute bed days by more than 10% over 5 years. And again, the 2019 Strategic Outline Case reference is on page 32. But the CHFT Future Plans Public Engagement Frequently Asked Questions say nothing about any of this. They do not explain that the Secretary of State's approval of the new buildings plan is only conditional, and that 2 of his conditions about the need for more information on planned hospital capacity and the actual performance of out-of-hospital services require this Joint Health Scrutiny Committee to tell the Secretary of State that the NHS organisations have provided care closer to home performance data that show the programmes are on track to reduce A&E attendance and to cut unplanned hospital bed days by more than 10% over 5 years, something this committee is so far unable to do. Nor does it say that when they rejected the 2016 plan, the independent reconfiguration panel told the NHS organisations that from now on, they must provide timely information to Calderdale and Kirklees Joint Health Scrutiny Committee, and they must avoid repeats of things like when they withheld the full business case until a last-minute private meeting with the committee immediately before its scheduled meeting in private. This is a requirement that the NHS organisations have persistently refused or failed to comply with, despite repeated requests from this scrutiny committee. For these reasons, today we're hoping that councillors will get this information from the NHS organisations, and if this isn't achieved, 999 Call for the NHS will be writing to the independent reconfiguration panel and the Secretary of State, asking them to direct the NHS organisations to immediately provide the required data about the impact, the actual impact of Calderdale and Kirklees Care Closer to Home programmes on A&E attendance and acute hospital bed days. Thank you.
Thank you, Jenny. I would like to make it perfectly clear that there is a difference between public consultation on planning applications, which are about buildings and the location that they're sited in, and the work of this committee, which is largely around the functions that those buildings actually provide and the way they fit into the overall provision of services. So I would see the two as being running in parallel, but not overlapping to any significant extent. So I think that needs to be borne in mind. But thank you for that. Thank you for the points that you've raised. Rosemary Hedges.
Thank you. Thank you very much. I'm speaking on behalf of Calderdale and Kirklees 999 call for the NHS as well. CHFT and the clinical commissioning groups have many questions to answer, we believe, and we hope councillors will make sure they do. The CCGs have failed to answer our freedom of information questions about care closer to home performance data since the start of 2018 that shows the service's impact on A&E attendance and emergency admissions and on cost savings. So we know nothing about that. And B, whether commissioners have the skills and resources to examine and interpret the data. A summary of key points in their response to the Freedom of Information request is on pages 7 to 10 of the attached report, which you should have received. Here are some of the most urgent questions to CHFT and the CCGs, which we hope you will get answers to today. 1, why haven't CHFT and the CCGs complied with the Independent Reconfiguration Panel's direction to provide timely information to this committee? And 2, why has CHFT engaged the public with questions about the design of the new hospital buildings without explaining A, what the capacity of the new A&Es will be, B, that acute hospital bed numbers will not be increased to accommodate the forecast increase in emergency admissions due to population growth, and C, what local data they have based these decisions on, including data about the impact of Calderdale and Kirklees Care Closer to Home programmes on A&E admissions. 3, have Calderdale and Greater Huddersfield, now Kirklees CCGs, given CHFT these data, either for the period since the start of CHFT's work on the revised plan in 2018, or for any other shorter period since CHFT started working on its revised plan? If so, will they immediately produce all of these data to this meeting? 5, if CHFT have not received these data, why does CHFT think it appropriate to carry out a public engagement on their new building plans without knowing whether the planned A&E departments and acute emergency beds will be safely able to meet the needs of the growing population? Will they immediately state their reasons clearly and unequivocally on their future plans engagement website and in a media release, and explain A, there's no evidence that planned capacity of the new A&Es and acute emergency beds is going to meet the needs of the future Calderdale and Kirklees population, since no expansion is planned to take account of demographic growth? Instead, the new building plans assume that Calderdale and Kirklees Care Closer to Home programmes will cut the need for A&E attendance and reduce emergency admissions by more than 10% over 5 years. But there is no evidence that the Care Closer to Home programmes are on track to make that happen. The Secretary of State has made it clear that he cannot approve the hospital's reconfiguration plans until the performance of the Calderdale and Kirklees Care Close at Home programmes have provided reliable, consistent evidence that they can reduce emergency admissions and A&E attendance to the extent that the planned capacity can meet the needs of a larger population. No such evidence has been produced. 6, have the NHS organisations considered the potential waste of public money if their plans for the hospital's new buildings have to be revised because there are no care close at home data to justify the Trust's decision not to expand capacity to accommodate forecast increased use of A&E and emergency beds due to population growth? And the final question, why have Calderdale CCG and Greater Huddersfield CCG, as was, failed to provide data about the impact of their care close to home services on A&E attendance and emergency admissions to a member of the public who put in a freedom of information request but has received no information on these matters? Thank you very much.
Thank you, Rosemary. I would say that this committee is very aware that 2 of the 3 recommendations from the independent reconfiguration report are related to the capacity of services that can be delivered by hospital services within the overall health scope of health services in Calderdale and Kirklees. That is a large subject. This is a meeting that is of limited time, unfortunately, and so we will be returning to this when the committee reconvenes after the local elections, and hope to give it the detailed scrutiny that you're requesting.
Thank you.
Can I also ask that the deputations that people have put a lot of time into are attached to the minutes of this meeting? I would at this point I'd also like to make it clear that we've received copies of solicitors' letters that have been exchanged that the committee is aware of. Thank you for the deputies. Can we move on to item 6, estates and service developments for Calderdale Royal Hospital and Huddersfield Royal Infirmary? I believe Anna Basford has some slides to share.
Thank you very much. I'll just put those on screen now.
That's fine, we can see them. Thanks, Anna.
Okay, I'm just putting them in full view.
Perfect.
Okay, thank you very much. I just have a number of slides that I'm going to present to you today. My name is Anna Basford. I'm Director of Transformation and Partnerships at Calderdale and Huddersfield Foundation Trust. We're sharing with you today an update since 2018, when we were awarded by the government £196 million for investment into healthcare across Calderdale and Huddersfield. This is one of the largest allocations of funding for Calderdale and Huddersfield in years, and we see this as a real opportunity to invest in services for everyone across Calderdale and Huddersfield. It's a lot of money, and we are really pleased to be sharing these plans with you. As well as the investment that we're receiving, this is an exciting opportunity that extends far beyond new buildings and bricks and mortar. For example, this is a real opportunity to create jobs and prosperity. It will be a real boost for the construction trade and associated businesses locally. It will enable us to support Calderdale and Huddersfield Kirklees to become a greener place, and it will enable a longer term investment into our healthcare services. This will enable a better experience and recovery for people that, for example, have cancer, have a stroke, or have respiratory disease. The developments will also help us to attract and retain skilled healthcare professionals to work in Calderdale and Huddersfield. Whilst the investment is exciting, we cannot escape that the COVID pandemic has had an impact on every person in our local communities and changed the society we live in. Sadly, too many people have died of COVID, affecting so many local families forever. More than 2,000 patients with COVID have been treated and discharged from our hospitals, but we know some people continue to experience long-term health impacts. There has been a disproportionate impact on Black, Asian and minority ethnic communities, widening health inequalities. Business closures, job losses and impacts on education will continue to have a long-term effect. We see these development plans as a key part of the recovery from the pandemic. We will work with our local authority partners and the business community to boost our local economies and help contribute to longer-term recovery. Kirklees Council has ambitious plans for supporting and accelerating economic recovery through investment in both their Huddersfield and Dewsbury blueprints. This hospital and community investment should work in tandem with these established programmes to tackle inclusivity and create employment opportunities for all. This investment will support Kirklees' ambitions for regeneration, enabling new jobs and skills development in construction and associated trades, apprenticeships for younger people, and in digital technology. We will be very keen to work with the University of Huddersfield in maximising these economic opportunities, and together the combination of our plans will reduce the overall local carbon footprint, supporting Kirklees to become a greener place. It's very easy to forget that HRI is over 60 years old. And since it was opened in the 1960s, healthcare technology has vastly changed. We now have the opportunity to secure HRI for the long term with a minimum investment of £30 million on much needed improvements to the buildings and internal infrastructure. A new and larger A&E department will be provided on South Drive, and this will include state-of-the-art facilities for patient care in a fabulous modern setting. Due to the pandemic, we have learned the value of creating separate COVID and non-COVID areas, and this separation will be built into the new design to ensure we can stay open in all circumstances. The design will better meet the needs of people with mental illness that attend A&E and also the needs of children and young people. Doctors, nurses and therapist colleagues are all very keen to see these changes. For them, trying to save lives through this pandemic has really brought home the need for these improvements. Calderdale Council also has ambitious plans to be a growing economy, which reduces inequalities and builds a sustainable future for all. The Council's exciting development plans include investment in flood defences, transport infrastructure, education facilities, state-of-the-art bus and rail centres and other town centre developments. Through this investment, we can contribute to recovery to get better social value from our spending and recruitment that will support towns, villages and communities to thrive in Calderdale. These plans will reduce the carbon footprint, supporting Calderdale to be greener. Our construction partners will offer work placements, apprentice roles and support educational activities with schools and colleges. At CRH, these plans will result in an expansion of hospital facilities and the provision of a new patient and staff car park, which will be designed with environmental sustainability in mind. COVID has really taught us that the co-location of acute inpatient services is essential to improving care. Our plans will provide greater resilience and enable us to maintain provision of care into the future. The plans include more single rooms and spaces to enable infection control. Equally important is that the build developments will reduce carbon use and emissions and help Calderdale to be a greener place. We are working with the IBI Group, who are award-winning architects with a wealth of experience in healthcare design. This includes one of the most digitally advanced hospitals at Chase Farm in North London, an environmentally sensitive development at Cockermouth Community Hospital in the Lake District. More locally, you may have visited Kirkwood Hospice and seen its pool and private garden areas for every room. This was a transformational and sensitive project designed by the IBI group. As is the case as we're experiencing right now, care should not be about very long stays in hospital. The risk of infection is ever present. Increasingly, hospitals like ours are providing treatments as day cases. Many services, such as specialist nursing, which were once provided only in a hospital, can now be delivered in the local community and in people's homes. We have no plans to reduce the services and beds across our 2 hospitals. The numbers will still total around 800. The pandemic and the exciting potential of technology has accelerated implementation of options that mean many people can now more conveniently access the care and support they need closer to home. Alongside primary care, Locala and other partners, this means our doctors and nurses can also reach out and offer more support to nursing and care home staff, as we have done during the pandemic. CHFT is one of the most digitally advanced trusts in the UK. This is one of the most exciting possibilities for the new plans, not just in terms of healthcare, but also with regard to higher education and associated job creation. We are and have been for a long time at the very forefront of technological developments, to the point where the Microsoft Global Chief Executive has positively referenced our use of technology to provide care and support to patients with epilepsy. Together with our local authority and other system partners, technology will be a very central part of the fabric of our 2 new hospitals and the services provided to people at home or other care locations. In championing such transformation, we are clear about the need for us to avoid digital exclusion. Therefore, whether we develop straightforward apps that may assist patients and their families to find their way around, or at the more advanced end, use artificial intelligence to assist clinical decision making, we will make sure that this does not digitally exclude people or exacerbate health inequalities. Going green is a given for us all across Calderdale and Kirklees, and we are keen to use this development to help both local authorities to go further and faster in terms of their place-based plans for the environment. We know the significant investments that are being made into the road infrastructure across Calderdale and Kirklees will reduce congestion and make public transport options more attractive and support alternate methods of travel such as cycleways. Our focus will be on sustainable travel and a reduction of unnecessary care miles through a range of actions. Where vehicle use is essential, the developments will provide on-site safe parking facilities with electric charging points. Our proposed timeline means that, subject to approval of planning applications, we will start building the new A&E at Huddersfield Royal Infirmary later this year in 2021. Next year, we will start building the new multi-storey car park at Calderdale Royal Hospital, with sustainability being a constant backdrop to our design and implementation. In 2023, the new A&E at Huddersfield Royal Infirmary and the car park at Calderdale Royal Hospital will be completed, and we will start building the hospital expansion at CRH. Many of you may have already attended meetings and have been part of our engagement events this year and last. During March, we are undertaking public engagement for people to share their views on our development plans via a dedicated website. All the feedback from this will be collated in a statement of community involvement that will be submitted with our planning applications to Calderdale and Kirklees councils in May 2021. We want to support building back community resilience and recovery. We all need hope and ambition for the future, and this investment is part of building confidence for a brighter future. We think these are ambitious plans that will create positive transformational change for our communities to improve the health and well-being of everyone in Calderdale and Kirklees. We are committed to leading the economic recovery from the pandemic, and schemes such as this one will play a vital role. And finally, I'll leave the last words of this presentation with colleagues from Calderdale and Huddersfield Foundation Trust, who have been heavily involved in all of our planning and are ready for the next stages. And I hope that you will be too. I'm very happy to take any questions, and I will stop sharing my screen now.
Thank you very much, Anna. That's great. Can I just start off by seeking clarity about the Accident and Emergency Department that's planned at Huddersfield Royal Infirmary? The NHS in England uses a system of categorization of accident and emergency departments, type 1, type 2, type 3, type 4. Which it would be helpful, I think, for people to understand which category the proposed service at Huddersfield will fall into. How is it going to be described by NHS England?
I would suggest that Mark Davies replies to that question.
Thank you. My name is Mark Davis. For anybody who doesn't know me, I'm a consultant in emergency medicine. I'm one of the clinical leads for reconfiguration at CHFT. I don't think we've defined what category of emergency department it would be. In terms of the categories that I used, a level 1 is described as a consultant-led emergency department, which will cater for patients with all presentations. So I'd imagine it would be that one, but that would be for NHS England to define rather than us. The key element of a category 1 emergency department is that it has ability for the emergency management of all patients who arrive. And we believe that the plans that we've got in place for the emergency department at Huddersfield will be the case, that we will have emergency physicians on site 24 hours a day as required for a level 1 emergency department. There'll also be senior anaesthetic support to the department 24 hours a day. What we will not have is the ability to deal with every patient who arrives all of the time, just as we don't have that ability at Huddersfield now or at Halifax now, and the vast majority of emergency departments across the country don't have, which is why we have specialist services at Leeds, at Bradford, at Wakefield, that we and the rest of West Yorkshire use on a regular basis. So I hope that can clarify things to a degree. What I can say is that we will have 24 hours emergency department specialists on site and critical care doctors or anaesthetists on site, so we can manage and stabilise any patient who does arrive and transfer them to the most appropriate place, whether that be Halifax or Leeds.
Right. Thank you. I mean, I think, as I say, I think as greater clarity as possible. If one defines it as type 1, then there are the co-locations of services that go with that. But it would be very handy to understand in greater detail how it will actually function in the various circumstances if it doesn't fit neatly into one of those categories.
Yes, absolutely. And I think it's worth noting as well that at the moment, I think it was mentioned earlier that the availability of surgical specialists, if we think about the situation at Calderdale Royal now, it's a level 1 emergency department, but there is no acute general surgical or orthopaedic provision on that site. So anybody who walks into that building who needs urgent intervention from a surgeon or an orthopaedic surgeon is stabilised by the emergency department staff and the anaesthetic staff on site there and transferred to Huddersfield. Yeah. And the same the other way around for unwell children who walk into Huddersfield.
Yeah, no, I fully appreciate that things aren't as neat as they might appear on
absolutely
in written documents. Councillor Smage.
Thank you, Councillor Hutchinson. Scrutiny, as you know, scrutiny is about evidence, and so it is Scrutiny needs to ask questions about the detail behind the presentation. So you mentioned about inequalities. I'd like to understand exactly how that you're going to address inequalities, both the ones that were known before the pandemic, but also the ones that have widened as a result. And you mentioned about the impact on the BAME community, but you didn't mention about the impact on people with learning disabilities as well. And so I would like to know how you're going to quantify how you're going to address the health inequalities that there are in Calderdale and Huddersfield. I would also like to make a point on capacity. I know this is for a future meeting, but though I saw some comments yesterday about the NHS needing to increase capacity in the future. And so when we're talking about capacity at another meeting, I wonder if you could quantify your calculations as to how you are predicting capacity in the future as a result of what has happened. Okay, but my question for just now is on the inequalities. Thank you.
I'm happy to start with a response to that. It may be that commissioning colleagues also want to contribute to that, because what I will say is it isn't a single organisation that will be able to solve and narrow the gap around the health inequalities that are prevalent in our communities. It is about working as whole systems in place with partner organisations, but really importantly with local people. And there's a number of examples of the ways that from learning from the pandemic, we've at CHFT brought into sharp focus some particular pieces of work to take forward to support this. So an example I'll share with you is in relation to those people waiting for treatments. And we know that unfortunately the pandemic has led to an increased number of people who are waiting for treatment. We are actively using inequalities data to understand any variation in those waiting times and to proactively ensure that there are not differential waiting times for different parts of our populations to address that inequality. So starting with looking at the services we provide in hospital, ensuring that the access to our care is equitable. And that includes, in particular, around learning disabilities that you referred to, Councillor Smage, and understanding for those people waiting for treatments who've been waiting for some time. We know that people with a learning disability, we need to make sure that the way that we provide treatments for them, that we provide the support needed when they come into hospital. And we're currently working through, as part of our recovery plan, some very targeted approaches to improve that access. We're working very closely with both councils around their action plans around inclusivity. So for example, I, through a role on the Calderdale Health and Wellbeing Board, I'm currently chairing the Calderdale Black, Asian, Minority Ethnic Action Plan for Calderdale, which is again working with many partners about what actions can we take with local populations to better understand their experience and what adaptations would help to support them. So I'll stop there, and I'm not sure if other colleagues on the call want to come in and add to that.
Does anyone from either CCG wish to comment?
Yes, sorry, I've just raised my hand. Am I okay to come in?
Yes, yes, please do.
Yeah, I think Anna's absolutely right. The work on health inequalities is absolutely a system focus, and we need to be able to build on what we've learned from the events of the last year, which has showed is throwing health inequalities into sharp focus. Sort of equivalent in Kirklees to the work that Anna just mentioned in Calderdale is happening through our Kirklees Integrated Health and Care Board, where we have our Commissioners' Council and the providers coming together on a monthly basis. We have health inequalities as a standing item on that agenda. And we are using that time to help us understand and drill down a bit more deeply into certain areas to understand what's happening. For example, a few months ago, we did a real focus on the areas of cancer and learning disabilities and the sort of inequalities that we were seeing. And as Anna's mentioned, colleagues in CHFT have done quite a lot of work to help us, a lot of analysis to understand the impact on particular groups in our society in terms of their ability to either access treatment or the rate at which they are treated. We do intend as a CCG working through the integrated partnership arrangement that I've described to continue that focus as we go into next year. There's a huge amount of learning to come through on the back of COVID, and colleagues will be aware of the many discussions that are happening, for example, around uptake of the COVID vaccine in particular communities. So our primary care networks are very focused on that at the moment. We had a discussion with them only this week about where they believe the greatest inequalities to be and what specific actions they can take. So yeah, I think I just support that we are working on this. We're doing it in the context as well, not just of what's happening locally, but the review that happened at West Yorkshire and Harrogate ICS level during the last year, and we continue to review the actions that were taken as a system. So yeah, that's it from me.
Okay. I mean, I do think that it's important that digital exclusion mustn't be added to and compound the inequalities. I mean, we've seen the impacts of digital exclusion on the educational system over the past year, particularly. We've seen the impacts on the retail banking system over many years, and we mustn't be aggravating that within our NHS, within the NHS systems. So I do hope that this is being actually actively considered in the reconfiguration proposals, as well as the wider health system development.
Yeah, and I would come back on that, Councillor Justin, as well, because we did have a recommendation in that report that we produced a few years ago about that the reconfiguration should help address inequalities, which is why part of why I was asking the question as well. Thank you.
Yes. Thank you, Councillor Smage. Councillor Swift.
Thank you, Chair. I have a couple of questions, if it's okay.
Yes, on you go.
Thank you. The multi-story that was talked about, Anna, I may have misunderstood what you said, but it sounded as though it was definitely going on the Calderdale Royal site. And I've had and other people I've had a number of reassurances that it won't be anywhere near the allotments, etc. Can you confirm that?
I just lost the last part of your question. Assurances that it's not anywhere near, and then anywhere near.
Yes, the allotments, etc. Or on the allotments, because we've had assurances it won't be.
Yeah, there's an absolute assurance that our proposed developments at Calderdale Royal Hospital do not impact on the allotments. So that's an absolute assurance. In terms of our proposals, we are preparing planning applications for permission to build a multi-storey car park at Calderdale Royal Hospital, but it will have no impact on the allotments.
Thank you.
Thank you. And I forgot what my other question was, so apologies. I'll let somebody else come in.
Okay, if you raise your hand again, if you remember what it was, Councillor Swift. Councillor Cooper.
So one of the criticisms that's been levelled is that the survey that was carried out was done in November 2020, just a few months ago during a pandemic, on which these plans are based. I'd be very interested in the response to that, to see what your view is. Is November 2020 representative of our sort of general transport movements, etc.? The other question I've got is about capacity, really, and about how how have we assessed capacity? Has that been done properly? Has that done properly? Have we taken into account demographic change? Have we looked at the things that the changes which are going to be happening within Calderdale and Kirklees, which will impact on whether, how much of these services are needed? And I'd be interested to know about how many people who are currently being treated in Huddersfield are going to be expected to move across to Calderdale, who will no longer be treated in Huddersfield and will move over to Calderdale under the new arrangements. How many will have to travel? Obviously there's the critical and acute services, which will no longer, as I understand it, under the arrangements, be at Huddersfield. So I guess that's going to have an impact on the movement of patients.
Thank you, Councillor Cooper. Who'd like to address those questions?
I'd suggest just have written them down. The first question was around the travel survey and the timing of that survey. And I was wondering whether my colleague Stuart Sugarman and or Nicola Bailey would like to answer that one, who've been closely involved in the work around the travel and transport plan.
Thank you.
If I could initially start in terms of the travel survey. So hopefully you can hear me okay.
Yes, yes, we can.
So yes, it was started in November 2020. And yes, it was during a global pandemic, but actually we got a really good response. We got 1,500 responses from staff, which is about 25% of our workforce. Interestingly, Leeds did a similar travel survey, not during the global pandemic and just before that, and got 2.52% response rate from staff. And also, just to make it clear, at the start of the survey and throughout, it actually said, please undertake this survey thinking about how you typically travelled before the coronavirus restrictions. So we needed to do the travel survey, but we tried to frame people's thinking when they were doing it, so not in the current climate, which was a pandemic, but pre that. Hopefully that helps.
Can I just, how many visitors and how many patients participated in that survey? Because all we've got is percentages.
Yeah, so apologies. Off the top of my head, it was about 240 patients and visitors completed the survey. I don't have a breakdown to my fingers on that. I mean, we did an awful lot of work trying to push this out and try to get a good response, and that wasn't a particularly strong response. I have to accept that. We did put a competition together to try and encourage people. Went through our sort of usual contacts to try and get the best possible response. But apologies, I don't have a breakdown and split on that.
Can I just query that again? You in your initial answer, you emphasised about staff and staff things, but and them making the point that that it was about pre-pandemic. But what about visitors and patients? What about them? Were they talking about during the pandemic, how they travelled at this time, or were they encouraged to think? They couldn't be encouraged necessarily to think pre-pandemic, could they? Because they were talking about how they travelled at that moment.
Yes, again, but there was a statement at the start of the survey. Please undertake this survey thinking about how you typically travel before the coronavirus restrictions.
People don't typically travel to a hospital. They usually do it because an event has happened in their or their family's life. It's not a common occurrence that they can talk about, like going to the shops.
I acknowledge your point. We've got regular outpatients and visitors that would make regular trips to the hospital, both patients and visitors. And we were just trying to acknowledge the difficulty that we were in undertaking a travel survey during the global pandemic and trying to get people to think about not just in the current climate, but how they might travel before the pandemic.
Okay.
So do you want me to picking up the second point that you asked, Councillor Cooper, was around how we have assessed capacity and the process for that. And as has already been referenced by Councillor Hutchinson, I know that the Scrutiny Committee will want to see further detail around this, so I don't have all the numbers at my fingertips today, but what I can tell you in terms of that process around capacity modelling, at the time that we produced the strategic outline case, that went through quite a rigorous scrutiny through NHS England, who looked at our plans based on our activity modelling and the projections forward over the next 5 years, and what would impact on that in terms of known changes in services and incorporated elements of demographic growth into that. So, as I say, I don't have all of that detail at my fingertips to be able to show you now, but that is part of the evidence. We can certainly demonstrate the underpinning activity modelling assumptions that have been used in the strategic outline case and going forward. Okay.
Does that answer your question?
And there was the question about the expected movement from Huddersfield to Calderdale due to the changes.
In terms of
who's going to go to Calderdale, how many people?
So in terms of that position, the services that we will be providing at the two sites, when you say how many people from one district will go to the other hospital, we have looked at total activity on the two sites, and both hospitals in the future will provide outpatient services, diagnostic services locally, midwifery services. And when we've looked at the total activity on the two sites, there is an equivalence almost of that volume of activity, because Huddersfield will have a high volume of planned elective services and Calderdale will have the high volume of acute inpatient services. So in terms of absolute patient, somebody living in Huddersfield may need to go to Huddersfield for acute inpatient care, but equally they will benefit from being able to access their elective care in Huddersfield. So I think, in terms of absolute numbers of how many people will need to travel, I think I'm conscious in this answer, it will depend on the nature of the services they require. And I've seen that my colleague Mark has put his hand up, which probably means he's going to give a far more eloquent answer than I have.
On you go, Mark.
No, Joel, I think the key thing is to remember that a significant number of Huddersfield residents currently go to Halifax for their care, inpatient care, and a significant number of Calderdale residents have their care at Huddersfield because of the way our services are configured at the moment. So there will be a movement of patients from one side to the other, but some will be coming back to have their care at Huddersfield, and some will be moving to have their care at Halifax, just the same as they will be vice versa. We can get an estimate of the net movement, and we know that inpatients are going to be a greater number at Calderdale, because the unplanned or the acute work needs more inpatient beds than the planned elective work. But at the same time, the planned elective daycare surgery, that sort of thing, the numbers are significantly higher. So in terms of numbers of patients, we can get you an estimate, but I suspect it won't be that different having it at Huddersfield or Halifax, but needing to be in hospital and admitted to a bed, there'll be a higher proportion at Halifax, to the tune of about 240 beds. Okay,
so what I was, sorry, just to probe a little deeper on this, there's, I guess there must have been some modelling done, because what I've had from you is these are qualitative answers, they're not quantitative answers, and I guess if you've done some modelling, you would be able to say, we have looked at X, Y, Z. This is our assessment of how many patients are going to be coming to requiring this service. They will go to this place. These are the amount of patients we've modelled to do this. I'm guessing this is the sort of business planning you would do in any case. So I would have thought you could point to something and say, here's the answer.
So all the calculations we've been doing to date have been predominantly based around how much space do we need to deliver the care, which isn't the same as how many patients.
Okay.
I can get you that data on how many patients, but in terms of the space that's required, our modelling is based on a 2% per annum increase in non-elective attendances to the emergency department and operations, which is the average of the last 5 years demographic growth before the coronavirus. So that's the best estimate we've got. And we've projected that forward 5 years to when the facility will open. But in terms of elective work, we planned on a flat rate because there's currently no plans to increase that, although the COVID backlog will need to have some amendments to that.
Sure.
I'm glad you raised that point, that last point, Mark, because certainly that was one of the things that I did want us to cover it probably at the next meeting, is the addressing the COVID backlog. Councillor Simpson.
Thank you very much, Chair, and good morning, colleagues. I hope you're all well. I just want to reinforce and support what Councillor Cooper said, and thank you, Mark, for your response. I think it will be very helpful if we could have those estimates and those details, and just say if we could, although we would greatly appreciate as much detail as you can give us, also to ensure that it's understandable, because sometimes we get information that's as non-clinicians is quite difficult to penetrate, if you understand what I mean. Thank you very much. As was reflected in the deputations, one of the key issues is integrated care close to home, having a demonstrable impact in reducing the demand for hospital services, not just for us, not just in the modelling, but seeing the real impact before the changes take place. I don't believe we as a committee have yet been able to see the evidence of the impact in a sustained way, though I do appreciate the confidence that there is in the likely impact of care close to home if working well. As a committee, we do need to see that in a clear and sustained way. And obviously a further challenge to that is that the last 12 months of data won't be particularly representative of a normal year, or what we'd understand as a normal year before the pandemic. And I know the Trust's really keen to make progress on your plans. Is the Trust confident of being able to provide us with the evidence that we need on the impact of care close to home in good time for us to be able to make an evidence recommendation that we're confident in? And if so, when will we receive it?
Who would like to answer that? Because obviously there's someone who knows more about what's happening with care close to home and its impact.
I'll make a start, Anna, and then if there's anything from a Trust perspective.
Okay.
So I think, Councillor Simpson, you're absolutely right. To be able to look at data that takes into account the last year obviously is going to be very skewed and not representative. So that's an added challenge with all of this. If you remember at the last committee, we were able to describe what each of the two CCGs was doing in terms of its strategy around care closer to home and the levels of investment. And I don't have all the figures at my fingertips that we might have talked about last time, but we gave examples, I know in Kirklees, of the sort of things we'd invested in, whether that related to support to care homes, the high levels of investment that are going into general practice at the moment, both locally on the back of the national contract, further mental health investment and further investment in community teams. So we went through quite a bit of that last time. Since then, obviously, we've continued to have a focused effort on responding to the pandemic, and a lot of our work in community has focused on that COVID response. In Huddersfield, for example, we have commissioned an interim community phlebotomy service to support with the levels of demand and backlog. We have continued to provide support to care homes over and above national requirements, and we've also got some dedicated services very specifically focused on the impact of COVID-19 so I don't know if you've heard of things like pulse oximetry at home, where there is equipment given to patients who meet the criteria to enable us to monitor patients' oxygen levels at home and hopefully ensure that that prevents an admission to hospital too late in the day. Also working with colleagues in the Trust to develop services for long COVID. So there's been quite a bit of focus on that over the last few months. What we intend to do next is we hopefully, fingers crossed, come through the latest wave of COVID and don't see that increase again, is almost going back to the work that we did a couple of years ago on we commissioned McKinsey's to do a programme of work for us. I want to go back and revisit that now, because that recommended 13 best practice interventions. We know we have done a number of them, but now feels like a good time in the light of COVID to go back and say, right, have we done absolutely everything that we recommended? Are there any remaining gaps? And actually, what have we learned from COVID that might have a sort of ongoing impact in terms of how we best deliver services? Because we know that the way that some things are delivered in community now was almost accelerated by the pandemic. So I think when we were coming and talking to you all a couple of years ago, we might have talked about things like remote consultations, for example. That was implemented almost overnight in general practice in response to the pandemic. And I'm not advocating for a minute that, you know, a pure remote consultation model is the right way forward into the future. But undoubtedly, it does work for some people. In the same way we talked about it for outpatients, it does work for some people in general practice. So there will be elements of that model that we can now maintain as we go forward, because it offers benefits. So, as I say, revisiting where we were when we did the McKinsey work a couple of years ago, and understanding the impact of as far as we can, the impact of the investments we've made in the light of COVID. That's something that we've now got focused on. I think what I'd probably then suggest we do, I know it does come up in this panel, but I think we have also always said that the place-based panels are very much where we'll have the main conversation about the impact of our care closer to home and community service type work. So I'd suggest from a Kirklees perspective, I can liaise with Richard about when best to bring that into the local panel as well.
With respect, I would suggest that it also needs to be discussed here, because we're looking, you know, we're being told over and over again that we're looking at integrated services, and Calderdale and Huddersfield Foundation Trust provides services to the whole of Calderdale and Greater Huddersfield. And so, you know, and because the services are distributed across the two different sites, I think this board is an appropriate place to be looking at the quantitative aspects of care close to home and its impact, not just the qualitative aspects. So I would be, you know, I do think it's important that we can reassure ourselves as a committee that the capacity is sufficient and doesn't just return to a steady state system that existed before the pandemic, because we're well aware that there's been a huge backlog of work that has not been done during this time, and that will need to be accommodated as we come out of the pandemic. Sorry to interject there. Councillor Simpson.
Yeah, just wanted to support what you've said there, Colin. I think I can completely appreciate what you've said there, Carol. And I do appreciate the work that's gone on and all of the investment that you talked about, which is all obviously absolutely welcome. I think my worry is that all this work, although it is ongoing and absolutely fantastic, I'm worried that it would, because sometimes, you know, we make these investments and they begin to pick up previously unmet need or newly presented needs. And of course, meeting those is absolutely essential and really good, but they end up addressing those issues and may not have the 10% impact on what we already know was there, because they're also picking up these previously unmet needs and newly presented needs, which is, of course, we'll have with, as you say, with long COVID. So as Colin said, I think it is really important for us as a committee to make sure that we've got that evidence base that we can feel confident in for making our recommendation. Not just about, you know, we've made this investment that works ongoing, but seeing clearly in a sustained way that impact that we've long talked about, that's really important for the reconfiguration.
Thank you. Councillor Munro.
Hello, thank you very much, Colin. I'd just like to provide a bit of perspective here, because currently Kirklees has a 2018 Kirklees had a population of circa 420,000, and Calderdale 210,000. So roughly 50% fewer residents live in Calderdale than live in Kirklees. So there's a huge imbalance in terms of population size. So going forward, government policy in the near future is likely to direct more house building in our areas in West Yorkshire as opposed to the south of England. So that means we're going to have an influx of people living in our areas. Kirklees has plans for 32,000 new homes to be built. Calderdale, 10,000 new homes. So my question in all of this is, I realise that I understand there was a strategic assessment done and it looked at the last 5 years of demographic growth and the future 5 years, but is that going to be enough? That is my question. How can we be assured that that strategic assessment that was done will be enough to adequately deal with the capacity of future growth in our area? And I've just given you the figures. And so I'm wondering, could that strategic assessment be revisited in the light of predicted increases with people coming and population growth in our area? So that's my first point. And then I'd just like to pick up on the parking. The plan is to increase parking by 50% at Calderdale, yet there'll be more additional staff surely working at the hospital. So my question is around capacity of the car park. Will that be enough? Will there be enough places for the public to park, because you're going to have additional staff parking there? So that's another concern I have. And then finally, we made several references to making Calderdale a greener place, but these plans should surely encompass and ensure the same for Kirklees too. So, and I question how you can reduce the carbon footprint, because people who are ill are not going to be able to travel to hospital on a bicycle or walk. They're going to have to be transported there, and they may be too ill to be transported on public transport. They will need private vehicle transport to get them there. So I'd really like some information, some actual quantitative information on quantitative data on reducing the carbon footprint, because I really don't feel that these plans will achieve that, because you're going to have huge numbers travelling from one local authority to another local authority and vice versa. And I do not see how this plan can possibly reduce the carbon footprint. Thank you. I'd like some data on that, please.
So thank you very much, Councillor Munro. In terms of the 3 questions that you've raised, I'm going to suggest take the sustainability one first around a greener place. And my colleague Stuart Sugarman will be able to respond to that.
Okay, thank you.
Thank you. You've raised a really big question, and I suppose it's how much time do we have in order to answer that? So in terms of what we're doing to reduce car use, I'd sort of point you to in the travel plan, promoting cycling, active travel, public transport. And again, for staff, we're creating sort of better shower and locker facilities for staff, improving bike storage. And all of those will hopefully encourage staff particularly, but also some visitors to reduce their car use. I think we always have to acknowledge that there will always be an element of people that will use cars inevitably. So we're installing electric vehicle charging on both sites and in the new multi-storey car park, and we'll be promoting car share schemes. We've already got a promotion of the Metro bus schemes, which we'll be using as well. Again, during the reconfiguration, we're developing park and ride for staff, which will help address some of the parking issues, and I can go into some detail in respect of that. In terms of about what we're doing about climate change and sustainability, without going into too much detail, but that sustainability is being incorporated throughout the design stage of the reconfiguration plans, and it's intrinsic to the programme. So all the works that we're doing have been designed to be as sustainable as possible. And I'm not sure whether you sort of picked it up, but we've committed to construct the new estate according to the BREEAM standard, and that will help ensure that it's we maximise sustainability in all areas. So ideas like energy efficiency, mitigating pollution, waste segregation, recycling. And I think Anna mentioned it previously, but we've committed to achieving a minimum score of good, but we're aiming and on track to achieve very good in respect of that. So I think we could go into some great depth in what we're doing to reduce our carbon efficiency in terms of that. So for example, we'll be incorporating low carbon heating within the design. We're including air source and ground source heating pumps. We're looking at solar, photovoltaic and other technologies. And again, reducing travel emissions will improve air quality, and the reconfiguration program is optimized in terms of service design to reduce the need for unnecessary travel. I'll pause there, and my colleague Rob may wish to add to that potentially if hopefully I've addressed some or most of your questions.
Okay.
Sorry, Alison, go on. Please go ahead.
Sorry, I just wanted to come back to Stuart, actually. I still would like some hard data. I mean, has an assessment done of the number of people currently being done on the number of people currently travelling from Kirklees or Huddersfield to Calderdale on the Halifax A629? Have we actually got some hard data on that, and has that assessment been done, so that we can then compare it with what you're planning in the future, so we'll know, is there some kind of measure that's going to be put in place, so we've got an idea, a real idea of actually that what your plans are going to actually work, or they will work. We need a basis to measure that, and I don't think that's really been done from what I can see. Yeah.
So just to interject briefly, so for example, in terms of the work that we've done for reconfiguration and the park and ride scheme that we're developing, we've done exactly that data. So we've analysed where, and this is just in relation to staff as an example. So we've analysed by postcode where they work, where they live, and then we've tried to design a park and ride scheme and other travel support based on where they will be moving to. So for example, we weren't looking to put park and ride in areas where we wouldn't necessarily use it, and then we picked that up in the travel survey as well. So we do have that data. I don't necessarily have all of that information at my fingertips as I sit here today, though. Rob may have more information on that, hopefully.
Okay, thank you.
The only thing, if I could come in, Stuart, that I was going to add is that there's a lot that we already achieved in trying to address our carbon emissions. So we've already embarked on an LED lighting replacement scheme at Huddersfield Royal Infirmary. We've recently approved a green plan for the next 5 years across the trust. This comes with an action plan that focuses on 10 key themes. We've obviously got our green planning committee, chaired by one of the non-exec directors, and Stuart also sits on that. And we've adopted green energy tariffs for our estate as well. So there's a lot going on behind the scenes. As Stuart mentioned, yes, we're aiming to address our travel-related emissions through the travel plan, but there's also other scopes of carbon emissions that should be considered. So as I said, we've got the LED, we've got the renewable energy tariffs. In addition to that, there's the work we do on the clinical side and looking at our emissions from anesthetic gases. So we are working to develop a baseline, which actually has been introduced in our green plan. And also now the next step is to try and reach our net zero target for 2040.
I think Councillor Cooper was wanting to come in at that point before we return to Councillor Munro's other questions.
I didn't want to do the obvious thing and focusing on the green stuff. But let's try and deconstruct a wee bit of this. You mentioned that we're aiming for the good and maybe the very good standard in terms of a BREEAM assessment. Now, BREEAM has a number of standards: unclassified, pass, good, very good, which maybe we might achieve. It then has excellent, and then it has outstanding. So of this six standards, we're aiming for about a third along. So we're not aiming for excellence. We're not aiming for outstanding. We might get very good, but we're probably going to get good. And so that to me sounds like the scope for improvement, really. And so that's I just like to understand that.
Okay.
One of the things I mentioned in a previous meeting was looking at the passive house standard for hospitals. Frankfurt have got a passive house standard for hospitals. That's a verifiable standard being built being built under to a set number of air changes per hour for buildings, and they are possible in hospitals because they have been done. I thought I'd throw that in. People say, "Oh yeah, we'll go in and have a look at it," and maybe they did. So I recognise that there are some positive things going in. I recognise that there's some solar PV, some air source heat pumps, or all those things are going in. But in terms of the BREEAM standard, this is not some sort of wacky-do green building. It's not going to be an amazing standard, and it would be it's overblowing it to say it would.
Can I come next, Stuart?
Please do.
Sorry, Mark. So in relation to the ED, the emergency department at Huddersfield Royal Infirmary, just to clarify from conversations with Mark McDonald, the target is very good with potential aspirations for excellent. Okay. Now, having spoken to Mott's recently and brought up conversations regarding passive house, because yes, from the outset we have said we will try where possible to implement passive design. I don't think the elevation from what we've heard from the architects of the ED design would allow for many passive principles to be implemented. What they've said is actually, even given considerations for privacy, clearly it's an emergency department, we need to make sure that people can't just view into certain areas. The solar gain just wouldn't be achieved to allow us to really benefit from that. But yes, BREEAM has a lot of other principles. So we're looking at a low carbon design, for instance. So one of the things under consideration at the moment is a building life cycle analysis, yet to be approved, but it's something that Mott's have said, if we do get the credits on that, it'll be fantastic. We're looking at a responsible source, or I should say a sustainable procurement plan. So that will embed, let's say, local sourcing. It will try to encourage a local workforce. We're going to try and specify for low weight building materials, recycled content, and also we'll look at the EPD, the environmental product declarations of some of the materials that come into the building's design. And that's all the things that BREEAM tries to really do. And actually, by going by for that very good target, we are setting a higher standard for ourselves.
Have you got a set target air changes per hour for the building?
Not that I'm aware of. Maybe it's something that I should take back to Martin and see if we get some feedback on that. I've not been copied into that part of the conversation.
Sorry, Councillor Cooper. I'm afraid we are fairly pressed for time for this meeting. So I do think this is something that we do need to return to and see what the carbon budget is that this building is working to, both for its construction and its their operations for the future, so we can clearly understand this. So if that's all right, can we return to Councillor Munro's other questions?
Okay, so and sorry, I was just checking I wasn't on mute. Your other question was in relation to the parking provision at Calderdale Royal Hospital and the overall change in number of spaces, and if that will accommodate an additional footfall. I'm going to ask Stuart Barron to answer that question.
Thank you.
Thank you, Anna. So as outlined in the presentation from Anna, we are looking for a multi-storey car park that will see the car parking spaces grow on site at Calderdale. The car parking is being designed to increase the net spaces on the existing front car park by nearly 700 spaces, so 699 is the current thinking at the moment, and that will provide an increased access for patient, staff, visitors to that site, and importantly, the ratio of car parking spaces per visitors improves from its current provision from that car park. So we're expecting, and the modelling suggests that will have an improved impact on access to the car parking for colleagues, visitors and patients going forward, as well as and as part of reconfiguration, post-reconfiguration, when the increased activity arrives on site.
Apologies, I missed those figures. Could you tell me what the existing number at Calderdale Royal is and what the number will be once the buildings are completed?
Yeah, so there's around 800 spaces on site at the moment, and there'll be post-reconfiguration. There will be, just bear with me a second while I get the number, around 1,300 spaces post-reconfiguration.
Right.
There are some revisions going on as we work through planning on those values, as you would expect.
Okay, thank you.
Can I just come in? How much can you tell me how many extra staff you expect to be recruiting for the Calderdale?
So we're not planning on the recruitment of additional staff within the trust's overall employment. However, there will be more colleagues expected on site over at Calderdale. Now that's broadly around 900, but that looks a really high number, and certainly in the context of the car parking. But what you mustn't forget in that context is that will be over a 24/7 provision. And what we've been able to do is, certainly as part of the pandemic as well, is move a lot of colleagues off site as well that previously were. So if you take me as an example, I've been into a hospital setting site 4 times in the last 12 months. So the technology that we've been able to adopt has been able to move people off site as well, and that can continue post reconfiguration as well.
Right. Okay. So there'll be roughly 400 spaces for visitors and patients, visitors. Yeah.
Thank you. I'm aware that we're, we've only got another half hour to go. We have covered, we've strayed into quite a lot of the transport planning aspects of this. So I'm not too concerned, but just if we can keep questions and responses reasonably brief, because there are a few things we need to sort out before the end of this. So Councillor Collins.
Yeah, I don't think mine's a question really. It's just a plea to go back to the lack of measurable data from the CCG and the Care Closer to Home groups. As a member of the North Halifax Care Closer to Home group, I know what's been commissioned. I know what's being put in, but actually what we've not got, and I understand to some extent because of COVID why we've not yet been able to measure it as much in detail as we'd like to do. So I suppose what I'm asking in terms of a plea is, we must not leave it as a committee too late to get this data, so that in fact, if any changes need to be made, with COVID taken into account as well, we can actually make those changes and change our plans. So it's a plea really, don't leave it till the last minute. Get the data as soon as we can, so that it can be used to amend the plans where they need to be amended. Because we're absolutely, from Calderdale's point of view, determined that Care Closer to Home works and we get those reductions. And if we don't, then that is going to be a disaster for us.
Thank you very much for those comments, Councillor Collins. I fully agree with you, and we've been trying to get that data for quite some time. So we need to double down on our efforts to make sure that we have it in good time before the outline business case is supplied. Councillor Smage.
Sorry, I wanted to say that I agree with those comments on Care Closer to Home. I have a few questions, so I should be really quick with my questions, okay? If you could just be concise with answers, because there's there's other questions that are needed as well. So finance, we haven't covered any update on changes to the financial case underpinning the proposals. So can we have details of that, please? The clarification on the timelines for the business cases, we need those. You mentioned that if you get planning, then you'll start building, but there is the final, the business case, the FBC. And so we need to know why you're not doing an OBC for HRI, and why you're going to full business case, and what the timelines are for that, because a lot of this work that we're asking for, surely you will be needing for the full business case. So my questions then is, why haven't you already got it? And the travel plan. Now, I understand why you've had to do an updated travel plan, because obviously this will be something that you'll be needing for your planning process. And I am not going into the planning process at all. That's not for Scrutiny to do. However, the 3.2 on patient and visitors results, when I read this, I just sort of went, really? Because it's obviously been taken at a difficult time, the survey, but it does contradict previous travel surveys as to distances travelled. It also contradicts the number of people travelling, patients and visitors travelling, and it does not in any way take account of the travel group recommendations either. And therefore, I'm wondering why that is, why it is so sketchy for patients and visitors results, and why it contradicts previous travel surveys. Thank you.
Thank you. Who would like to kick off?
I'd suggest your first question, Councillor Smage, was in relation to the financial modelling that will be in our business cases and our approach to that and the underpinning principles. And I think that's in a context of the way that overall NHS finances have changed in the last year. So Stuart Barron will be able to respond to that one.
Yes, thank you. So the financial modelling for our two business cases you referenced, and I'll pick the other elements of points up as well during the answer. We're commencing the modelling for the financial modelling for the HRI business case in the next couple of months, with the intention that that will be developed as a full business case for HRI by May. That's our internal deadline that we're looking to do. And that will then be a published, well, a document that the board, our trust board, will consider going forward. And the financial modelling for the outline business case will be done later down the line, so across the summer months, with the intention that that will be available for our trust board approval in August, I think is the deadline. Submit, yeah. Approval in August. So they're the deadlines. You asked in and amongst the questions around why we are moving to an FBC for HRI's business case. There are a couple of reasons for that. So the first one is that's our regulators' guidance, is that the size of the investment into that estate, we're expecting a broadly £10 or £11 million investment for that HRI development, and the NHSE guidance is business cases and investments that are below £15 million can move to an FBC throughout, rather than going through an OBC, and that's about the level of cost incurred in developing that business case.
And I just roll back just that a minute, because I thought it was 30 million in HRI.
There is £30 million of investment overall in HRI. What we've done, and this is the second reason for it, what we've done with this is to pull forward the investment into the emergency department ahead of the programme for the outline business case and full business case as part of the total reconfiguration. And that's about managing the estate risk that exists at HRI, and also bringing forward that modern facility that Mark described earlier on at HRI as soon as we practically possibly can. So there will be £30 million overall invested in HRI. The phasing and time of that is different. So the residual element of that investment will be picked up through the outline business case for the total reconfiguration. but also might see, we'll see that potentially invested after that outline business case development as well.
Could I just on those timelines that Stuart's outlined there around our business case? I think Stuart's referenced our internal targets that we're working to. I just want to be absolutely clear with Scrutiny, that would be the earliest date when we are targeting to have completed those business cases. They will have a due process both internally and the trust to go through. So I don't want there to be an expectation those documents would be available and visible at those dates given. I think it would be the dates that we've written into the update report today is around business case development for Huddersfield Royal Infirmary by August, and the Calderdale Royal Hospital outline business case by November.
Thank you, Anna.
Can I just clarify the timelines for submission of the business cases to this committee as distinct from the submission of the business cases to NHS England and the Department of Health and Social Care?
So in terms of the dates that we've referenced in the documents, we're looking to at those dates in August and November that we will have submitted those documents. Having agreed those as a trust, they then go forward into a process, as you know, of quite a rigorous due diligence and review by NHS England. So at that stage, they are submitted to NHS England as draft documents that could be subject to change based on the advice we receive from NHS England, Department of Health, and possibly Treasury advice into those documents. And in terms of the availability of those documents, I also want to be clear, there will be a need for some redaction of elements of those documents because they would form the basis or will contain information on which we will subsequently undertake a significant procurement exercise for a construction partner. So there will be absolutely some elements within that in that context of a broader competitive process, you would expect that we would need to redact. So we would need to undertake that work. So I think you're looking to the late autumn time, by the time I think that we've completed documents, undertaken necessary essential redaction, which is not about a lack of transparency with Scrutiny, it is around that commercial procurement will be undertaking subsequently.
So you will have nothing that you'll be able to show in terms of planning, scheduling meetings and things like that. You don't anticipate having anything to share with this committee until late autumn.
In terms of what you would recognise as a business case, but in terms of the points that you've raised today of wanting to see more evidence around care closer to home, more detail around sustainability, about the ongoing involvement in Scrutiny across the range of questions that have been raised today and also included within the deputations, we are of course very happy to come to Scrutiny Committee and provide that information. I just wanted to be very clear about the product of a business case will be later in the year, but we will share with you and happy to respond to your questions as you request.
That clarity is appreciated. It's, as I say, it's so that we can plan the work of this committee over the summer. That really wanted to be clear on that.
Yeah, can I just come back on that, because I actually think that Scrutiny should be looking at the information that's going in the business case in tandem with it going to the NHS, because Scrutiny needs time to look at that detail. So we need to see as much of that full business case as we can. Scrutiny also has to satisfy itself that the financial assumptions that are made support the reconfiguration, etc. And I think it's also a little misleading to say that the full business case is for Huddersfield and the outline business case is for Calderdale, because as now, as I understand it, the full business case is only for the A&E part of the Huddersfield reconfiguration, and the remaining full reconfiguration is in that outline business case. And I think that we need to fully understand that as well, rather than saying one's for one and one's for the other. But Scrutiny, we need to find a way of scrutinising this full business case information as soon as we can, as soon as that's available. Okay, so I think Colin, you and I need a discussion with the trust about that going forward, if I can suggest that. Thank you.
Sorry.
I was just going to say thank you very much, Councillor Smage, for clarifying that point. I wouldn't have liked what I've said to have caused a confusion around the content of the outline business case. And your summary is absolutely correct. Thank you.
Thanks for that. Councillor Swift.
Thank you, Chair. A comment and then a concern. The comment is actually on the car parking, because staff, or they were when I was there, are not having to pay for parking. I was told that people were not taking advantage, as they should, but they were taking advantage of being able to park. And that way, you know, a lot of those spaces were taken up. My other thing is care nearer to home. We have been plagued by this comment for years now. I think the first time I ever went to anything about the hospital, it was, you know, care closer to home. I am not sure that we are much nearer with this. I can only speak for Calderdale, but the primary care and surgeries and doctors in Calderdale are, well, they're not doing anything wrong and they're trying to do the best. But, you know, I should imagine most councillors have taken a lot of calls from residents who don't know what they should be doing and, you know, all that sort of thing. So it really has got to be seen to, you know, work and the, you know, and the primary care fit in so that people can take it on. Thank you, Chair.
Thank you, Councillor Swift. Right. In the remaining part of the meeting, can we turn to item 7, which is the travel and transport update, which we've received the report, and obviously a number of comments have been made on that already. So I don't think we need to have a presentation on that, but there may be some points for discussion. Can I kick off by just saying that there was an independently commissioned travel and transport plan published in I think it was January 2018, which made quite a list of recommendations, which are also reiterated in the strategic outline case that was published. We've been told in this report the responsibility for travel, transport and highways is led primarily by local authorities rather than the NHS, which could possibly give the impression that it's over to you guys rather than something that the trust wishes to engage with. But one of the key recommendations of the independent chair was that the local NHS consider identifying a board-level transport champion to work in partnership with Calderdale and Kirklees councils, the West Yorkshire Combined Authority and other key players. To my knowledge, no such position has been established, but I would have thought that given the recognition that this needs to be integrated with the local authorities and the combined authority, that somebody should be responsible for actually trying to pull this all together. Can you just let me know whether somebody has been appointed to that role?
Yes, absolutely. Stuart Sugarman, who's on our call today, is our board level director lead for travel and transport in the trust. And I'll let Stuart come in and he perhaps can assure you also about an ongoing dialogue with West Yorkshire Combined Authority.
Thank you. That would be great.
Yes, sorry, just checking I'm not on mute. Yeah, so we do have a continuing dialogue with the West Yorkshire Combined Authority, and that's to seek the improved provision of commercial bus services between the two sites. And clearly the new road infrastructure that's happening as part of the works that both councils are doing will be a key enabler for that. And I suppose we're happy to answer any questions that you may have in respect of that. There is, of course, a commercial bus service. I think it's the 343, which is available, and it does link between, as I understand it, between the two hospital sites. And I think with the ongoing dialogue that we have with the combined authority, that's something that we would wish to involve both councils with that, and how we can develop that further.
Okay, thank you. There are specific points about the shuttle bus service. The recommendations were made by the independent chair that be substantially upgraded so that it's suitable for patients, including people with wheelchairs and limited mobility and children, whereas the shuttle bus service currently is very much directed at staff traveling between sites. Further, there was also quite a lot of comments of improvement, recommendations for improvement to the patient transport service, which I know from my personal experience didn't start early enough in the day to be able to get patients to hospital in time for morning operating lists if they were being operated on the same day as they were coming into hospital, and that if evening clinics were running, there was no ability to get the patient transport service stopped sort of before evening clinics and any later demand was required. So I'd like to know whether those two elements, the shuttle bus and patient transport service, are being addressed.
The shuttle bus in respect of staff is being addressed, and we are making changes, but the Trust's view is that the shuttle service is only for staff. And I think that they've previously given that view. And I suppose we've previously advised that we think bus services should be provided by bus providers rather than the Trust, given that they've got the licenses, the experience and the infrastructure. That's not to say that work that we're doing for shuttle improvements in respect of staff, that is ongoing, and we're looking at changing the route, trying to collect more staff along the route. We're looking at park and ride options where staff would be able to park and be collected. So for example, Broad Street Plaza, we're taking additional spaces there. Cedar Court at Ainley Top, we're taking additional spaces there, and then through Elland, but all of that does relate to staff rather than patients and visitors.
Right. Yeah, I think this is something that we're going to have to return to, but Councillor Smage, you have a question? And then I think we're going to need to wrap things up. Sorry, you're on mute, Councillor Smage.
Sorry, I lowered my hand instead of press the mute button. You'd think by now I'd know what to do. Yes, it is about the shuttle bus. That was a definite recommendation, and it's not as if this hasn't been done before. It was done in another reconfiguration in the northern part of Kirklees, and the Trust worked with the combined authority, and there was a shuttle bus put on. So there was a sort of a park and ride availability for patients and visitors between the hospitals. And in actual fact, it has now been taken on by an operator. It's no longer, as far as I understand, before pre-pandemic anyway, it was, as far as I understood, it was no longer supported. It was a bus service that had so many people using it, it was commercially viable. And that was, it is a shuttle bus between hospitals. And therefore, on your travel and transport documentation, there is nothing for park and ride for patients and visitors. And I would have thought that that would have been, with your green aspirations as well, that would have been something that would have helped your car park situation in Calderdale, splitting up the car parking a little bit more across the two sites. Thank you.
If I may, I know we're short on time, but if I may, just to respond, Councillor Smage, to that, the example around the provision of services at Mid Yorkshire hospitals and the shuttle services, I think is what we're trying to emulate in our discussions with the West Yorkshire Combined Authority. We recognise that is an excellent model. And I think the point that Stuart's raised is that in terms of providing bus services, the West Yorkshire Combined Authority has the ability to help with operators, provide a more robust infrastructure for that and with the necessary skills, but that's exactly what we're seeking to achieve.
And so just to add, if I may, so we were in discussions with the Combined Authority pre-pandemic. We, to be fair, we have been a bit wrapped up in the pandemic, but we've got ongoing discussions with the Combined Authority to do exactly that.
Okay, thank you very much. I think this is something that we will be returning to because it is a key issue in trying to make sure that there is equity in service, that people's access to health services are not limited by the costs of accessing transport to get to those services. I'm very conscious that Councillor Anne Collins has been a member of this committee for many years and has contributed much to it. Anne is standing down at the coming local elections, so I would like to extend our gratitude to her for all her contribution to the work of this committee over the years. Thank you very much, Anne, and you'll be much missed.
Yeah, can I support those comments, Councillor Hutchinson?
Thank you. We need to set a date. That, as we've discussed, there are a number of pressing issues, particularly around evidence that care close to home is matching the assumptions that have been laid out in the strategic outline case for modelling the capacity of the hospital services. And so I think we need to make progress with that as quickly as possible. Obviously, with local elections coming up at the beginning of May, this committee will be reconstituted subsequently. Can I ask Carol and our CCG colleagues whether they have any views on potential dates for the next meeting for this committee in June? Or whether this is something that we will need to sort out outside of this meeting. But can I leave you? I would hope that would give sufficient time to get together the information that we need, and Councillor Smage and I will be very happy to have an informal meeting to try and outline the information that would satisfy us that we've got a clear picture of the delivery of care close to home and how it matches up with the assumptions in the capacity plans in the strategic outline case. Other issues that we'll be wanting to return to are a written report on the financial case underpinning the strategic outline case, including the impact of the write-off of the Trust's historic debt, the impact of the pandemic and the recovery projections, and the impact on the financial case and the changes in NHS financing that have taken place with the rollback from payment by results to block contracts, amongst other things. And we will want to revisit both the travel arrangements, and I'm really glad to hear that we have a key person to link into now about the travel arrangements, and the further details about the carbon budget that the building work and the subsequent operation of services is working to. So if we can, if work can be done to make sure that those kind of that kind of information is available to this committee. Is there anything else that Councillor Smage that you think ought to be built in?
No, I think the capacity and the quantifying the capacity is a key thing, isn't it? Which goes to the care closer to home as well. So we need to be assured that the hospital capacity planning is fit for purpose now and in the future, bearing in mind the capacity needs that will be needed in the future, maybe because of the changes that have happened over the past 12 months.
And certainly in the strategic outline case, it's referred to the modelling being revised for the submission of the next level of business cases. Also, there was in the strategic outline case, the modelling of the Yorkshire Ambulance Service requirements would be revised before the next business case is submitted, and I think we will need to be seeing that modelling as well. So, thank you very much for your attendance. I think we've managed quite a lot in quite a short time. So,